Thank you very much. I have the honor of being the after-lunch speaker, so I'll try to be amusing. First, my disclosure. I have no current relevant financial or non-financial relationships within the products or services described, reviewed, evaluated, or compared in this presentation. That said, this research was all funded. Here are the funding, both VA, HSR&D, the Rhode Island Foundation, and Boston University through an R21. I'm a VA employee. You heard that. So I hope today to talk about the construct of participation and discuss some of the key measurement issues in addressing participation, and provide some background information on why we needed a measure of participation for veterans, and then describe the process of development and testing of the CRIS measure and the CRIS-CAT, the computer adaptive test version of the measure. I've been working on this area since 2003, so we have a lot of research, and hopefully I'll walk you through it rather quickly. How many of you here work in the Department of Veterans Affairs? I know there are a number of you. Okay, so there's some. But this line of work came out of the news and the recognized need for veterans returning from Iraq and Afghanistan. We call that Operation Enduring Freedom, OIF, and Operation Iraqi Freedom. And the returning veterans, it was very soon apparent that there was a high prevalence of traumatic brain injury, post-traumatic stress disorder, depression, polytraumatic injuries. And we knew from the Vietnam veteran experience that demobilization from combat and returning home can be very challenging, particularly so if you have had a co-occurring physical injury. My background is as a physical therapist, and I have always believed that the ultimate goal of rehabilitation is to return people to their life role functions. And community reintegration is the return of individuals to their age, gender, and culturally appropriate roles at as near as possible as their pre-injury level of participation. So this is the outcome that is most valued by our patients, by their families, and by society. How do we assess community reintegration? So this was our challenge. We looked to the ICF model of functioning disability and health to conceptualize and operationalize the idea of participation. And I'm sure most of you are familiar with this model, so I'm not going to walk through the model except to say that participation and that aspect of the model is what we're interested in defining community reintegration. So participation, according to the ICF, is involvement in a life situation, and participation restrictions, using the ICF taxonomy, are problems an individual may experience in involvement in life situations. So if you're familiar with the ICF, you know that even though that conceptual model shows nice distinct domains of activities and participation, in reality, the ICF domains of activities and participation share one common taxonomy. And they have, there are 9 chapters of activities and participation, and these include everything from learning and applying knowledge, general tasks and demands, communication, mobility, domestic life, self-care, interpersonal relationships, major life areas, which includes employment and being a student, and community, social, and civic life. So all of those, and there's the taxonomy that describes within each of the chapters are activities and participation. So our goal was to develop a new participation measure for veterans. We developed it, and I'll tell you about it. It was called the Community Reintegration of Service Members Measures, the CRIS. But in developing this measure, we had to grapple with many of the issues in conceptualizing and measuring participation that have since been well described in the literature. And as I said, we started this work in 2003, and we had to learn some of the lessons and come to our conclusions, and there's since been quite a bit of discussion about some of these issues. So the ICF, although they share a similar taxonomy, they propose several different methods for distinguishing between activities and participation. So there's an annex of the ICF, Annex 3, that gives options for how we can tell the difference between items that are activities and items that are participation. So the options are to exclusively designate some of the chapters, some of the domains, as activities and others as a participation. And Whiteneck and I don't know how we, Dykers, advocate for this approach. They say the last 3 chapters, those are participation, and the other chapters, those are activities. Another option is to designate some domains as activities and others as participation, but there can be some partial overlap. The third option is to designate all the broad categories as participation and then all the detailed taxonomy as activities. And then the fourth option is to consider all the codes as both activities and participation depending on their context. So these are 4 options. So in this last option, complex functional tasks would be considered participation, and simple activities or simple tasks are considered activities. Another issue that we grappled with is who gets to define participation. So each chapter has multiple sublevels. If you're familiar with the ICF taxonomy, it's quite extensive, and there are hundreds of categories that describe activities and participation. So it's important for the population to identify which specific elements are relevant to measure and would be most pertinent clinically, and that we would anticipate we would target our treatment towards, and we would expect to want to change with treatment. So we recognize that the important elements could very well vary by condition and population. And there's been a lot of work done in the development of ICF core sets for common conditions. And some of you may be familiar with that work, often done through large consensus panels where clinicians and stakeholders identify what are the relevant aspects of health and functioning that should be measured with this condition, and then they come to some agreement. These are the things that should be in the core set. Now, as I mentioned earlier, there's a strong advocacy that just 3 areas of activities and participation of those chapters be considered in the taxonomy: social participation and relationships, the interpersonal relationships chapter, productivity and economic participation, which is the major life areas, and leisure and recreational participation, which is community, social, and civic. We took a different approach than this and recognized that participation is involvement in life situation, and that participation can and does occur at the person level, not always in relationship to other people. So we looked at the idea of adult role functioning and some of the things that adults might do in their normal roles that could be done alone and not in the context of other people, such as engaging in hobbies, planning and cooking a meal, some complicated activities that are obviously, in my mind, more than simple tasks: managing daily schedules, taking care of health, managing stress, maintaining hygiene and appearance, planning a trip, following complex directions, even driving and obeying the rules of the road. These are more complex items that we considered participation. So we held the view that participation was an involvement in a life situation, and it did not need to happen in relationship with other people. It could sometimes happen in adult role functions that were done individually. So this really is a view that contrasts with the idea that role performance happens at the social level, and social roles are by definition done by other people. This is also in contrast to the approach that the PROMIS measures used in their measure of social health. They weren't developing a participation measure, they were developing a social health measure. social function, and by definition, it was involvement in and satisfaction with usual social roles in life situation and activities. So that was one issue that we grappled with. How are we going to distinguish between activities and participation, and which approach would we take? So we took that fourth approach from the annex, considering all activities and participation taxonomy as potentially either, depending on the context. So the other issue we had to grapple with is what aspects of participation would we measure? There are different ways of looking at participation and different kinds of things to assess. For example, one could assess the performance of roles, so the degree to which you take part in a role, say the frequency. These are common survey questions that you might have. How often do you go to the movies? How often do you go out to dinner with others? How frequently do you do certain types of, how often do you get together with friends? Another possibility is to ask people to report the limitation they have, or their difficulty, or their restriction in performing their role functions. So these are questions that would be like, how much difficulty do you have in getting around in your community? Or how restricted are you? Or how much limitation do you have? So these are limitation or difficulty restriction. And a very different approach to measurement is to asking people how satisfied they are with their participation in their roles. So how satisfied are you with the amount that you get together with friends? And that could really be quite different for different people. Some people might say, I get together with friends once a week, and that's very satisfactory. Other people might say, I get together with friends once a week, and that's really not enough. I'm not satisfied. And then there are some measures of participation that look at the importance of an item to an individual. So how important is this aspect of role functioning? There are other measures that also look at autonomy. How much independence do you have? And there's also a measure that looks at your sense of enfranchisement, or how much you belong in certain situations. So there's very different approaches to measurement of participation. So any kind of participation measure what you think needs to take a stand on which dimensions to measure. Other issues in measurement of a broad construct like participation is whether it's a unidimensional construct or if it's a multidimensional construct. And this is sort of controversial, because if it's a unidimensional construct, then you can score all these participation elements on a single scale. If it's multidimensional, then we might need separate scales, taking a more clinometric approach. And so that needs to be shown in the data so you can understand how you can score a measure. So now let me tell you a little bit about the development of the CRIS measure. I'll just quickly walk you through these, and then I'll tell you a little bit more about each of the steps. But we conducted formative research with injured veterans, their family members, and their caregivers, and with clinicians. We did a large review of existing measures, and we developed the initial item set. We did cognitive-based testing of the item set and revised it. We developed a fixed form measure. It was always our intention to develop a computer adaptive test. We had many, many items. So those were tested in a large field study with a 1-year follow-up. We also then tested the fixed form with a severely injured population. We looked at how the test could be administered. Could it be interview administered? Could it be telephone administered? And were there differences in responses with the mode of administration? We also developed an audio-assisted version of the CAT software, so it could be self-administered for people who had difficulty while reading and with attention. We've also tested the measure in a mild TBI population. So I won't tell you about all of those things, but generally this is the scope of work that's been done over the last 8 years. So we use the ICF framework to understand the challenges in community reintegration of injured service members. So we designed and tested the new measure, and we called it the CRIS. We considered this was a population-specific measure for veterans. And when we did the formative research, we used the ICF taxonomy. I'm sorry, this is jumping ahead. We used the ICF taxonomy to identify the participation items or the content that should be in the scale. We took, as I mentioned, the fourth approach, where we considered all items, either the possibility of activities or participation, depending on their complexity. And we decided that we would include objective, subjective, and satisfaction aspects of participation. So we have 3 separate scales that measure those 3 different dimensions. Okay, I told you why we needed the measure. We have a lot of returning service members. There's over 2 million now who've returned from combat deployment, sometimes multiple deployments. There was no measure that addressed the key issues of returning veterans. In the formative research, we conducted in-depth interviews and interviews with healthcare providers. We took all the transcripts from the interviews, and 2 coders independently went through them, and we used the ICF taxonomy to identify the challenges that the people were talking about and to code them according to the ICF. And then we further classified them as deep down into the ICF taxonomy as we could. So the concerns identified then were cataloged, so we're trying to find out what should the content of this measure include. We have a lot of options. We also reviewed over 20 other measures and every item from those measures to look at what currently existed. So we coded all these other measures. And we found that existing measures didn't really have the content that we needed for this population. For example, we found that most of them lack questions about attention concentration, coping and stress management, driving, alcohol and drug use, and social isolation. I'm going to just give you a couple of quick examples of the data to give you a flavor for some of these issues of maintaining a job. So these are some rich text examples from some of our qualitative interviews. And here's the girlfriend of an injured service member talking about the challenge her partner had in learning and applying knowledge. She said, "He's very unfocused. For him to read that document you just gave me on Monday," which was the informed consent form, "that would stress him out. That is going to extremely stress him out to read those 4 pages. Yeah, I can prepare him and say they're going to give you a 4-page document that you need to sign. Explain to him what it is. He will lose half of what I'm saying to him by the time I'm done." So we heard a lot of people talking about difficulty reading complex materials and problems with attention and focus. We had a lot of our interviewees talking about difficulty they had with driving. And driving is an aspect of mobility, and I suppose as a physical therapist I hadn't necessarily been thinking about transportation and transportation restrictions, but a lot of these folks had been gunners or tank drivers, and they had some serious adjustment issues returning home to driving. So here's one of our injured service members saying, "I seen items, it was just regular garbage. It seemed like something that was going to possibly cause harm to somebody, and I felt the need to just get away from it because when you get anxiety, you get like pressure in your chest and your throat gets all choked up. You have a hard time breathing. I seen it coming. It's like you hold onto the steering wheel real hard, like I'm waiting for another bomb to go off or something, and then I didn't even look to see if anybody was near me. I just rammed off to the side and came around it just to get away from it. And you step on the gas and just speed right by it." It's not a surprise then that several years later the reports started to come out about the increased motor vehicle accidents for service members who had returned. But there are many restrictions in mobility. There were a lot of discussions about tolerance and interpersonal relationship and the impact of combat experiences on personal relationships. Here's one of our interviewees saying, I just have low tolerance for stupid stuff. God, about a month ago, I was at McDonald's with a friend of mine, and the lady in front of us was just taking forever, and I'm like, Christ, lady, it's the same menu in every McDonald's all over the country. Like, order something or get out of the way. And everybody was like, everybody in the restaurant just kind of looked at me, and she moved out of the way, and we ordered, and that was that. And I have other examples, but for the sake of time, I'm not going to go through them. Here's an example of someone, punching out someone because he was annoying him in the mall, and people talking about their desire to spend time alone and socially isolate themselves, and so on, just to give you a flavor for the data and the kind of items that we felt were necessary to add. So the formative research, if you're interested in it, was written up in 2 papers. One was on using the ICF taxonomy to understand the challenges of service members, and the other one, I actually can't see that far. We did a large review of participation measures, or measures that covered at least 2 chapters related to activities and participation, and we did a large content review of those, so that was also published. So as I mentioned, do you have a question? I can't hear you. The second was in archives. It was a review of measure, archives of physical medicine. And on the handout, I think I've given you all the citations that I show here, so you can find those papers. So we decided that the CRIS would assess 3 concepts: perceived limitations in participation, frequency and amount of participation, and satisfaction with participation. So basically, we can say we have objective, subjective, and satisfaction elements. We decided in wording the questions that all questions would address a current life situation. We would not ask people to compare themselves to life before they were injured or before deployment, or to those people who hadn't been deployed. There are different strategies in writing questions, and we just made these decision rules about our questions. We would ask people not to attribute their state to any injury or illness. They just would to report on how they functioned or perceived their function within the last 2 weeks. So there are 3 scales. We developed a fixed form, which was 150 questions, and it in total takes 30 to 35 minutes to administer. That form is available if anybody is interested in the fixed form. So we did some initial testing of validity of the scale. We did a small pilot of 50 veterans. We looked at preliminary IRT to examine the dimensionality. We looked at the differences in the scores between people who were employed, those with and without PTSD, those with and without depression, and we showed that those variables, that the CRIS was different, the scores of the CRIS were different for people in those categories. That gave us good hopefulness. The scales were unidimensional. We did find that some items didn't seem to fit and needed to have revision, but there was good internal consistency. So as I mentioned, veterans who are working had better scores as compared to those retired or not working. Veterans with PTSD had worse scores as compared to veterans without. Veterans with depression had lower scores on the satisfaction with participation scale. So we thought these results showed us that the CRIS had good construct validity. So we revised the items that we felt misfit, and we cognitively tested new items. And then we conducted a second pilot study of 75 veterans, and we gave the CRIS measure twice within 1 week because we wanted to understand what its retest reliability would be. And again, we repeated the similar analysis. We looked at the dimensionality, the internal consistency. This time we added retest reliability, and we looked at differences between groups. And we found, again, the scales appeared to be unidimensional. They had excellent internal consistency, and they had excellent reliability. Veterans who were working had better scores compared to those who weren't. Veterans with PTSD scores had worse scores as compared to those without PTSD. This time we looked at substance abuse history, and veterans with substance abuse history had worse scores as compared to veterans without, and veterans with any mental illness had worse scores as compared to veterans without. I just wanted to give you an example of how some of the CRIS items were framed, and actually I'm going to use the next slide, which is communication. So this is how we coded the questions. So every one of our interviews, we had content area coded by the ICF categories, and the participation, activities and participation taxonomy are D codes. So under communication, this is the code D, I think it's 350, conversation, and that's the definition to the right in the taxonomy of that D code. So we did not write these definitions, these are from the taxonomy. And so we realized we needed questions regarding conversation from our interview, from our formative research. And so these are examples of questions for each of the 3 scales that touch upon this area of conversation. Because we had the knowledge that there would be a fair amount of our veterans who had mild TBI, we were not certain whether or not that would always be diagnosed. We were concerned that people may not have the self-awareness necessarily to answer questions about their behavior. Well, we had some advice to word some questions about how others felt about you. So this is done in some other tests, but the first question, perceived limitation, others felt that I interrupted inappropriately when we were talking. Extent of participation, when speaking with others, how often did you interrupt them inappropriately? And satisfaction with participation, how satisfied were you with the way that you participated in conversations? So these are examples of questions that touch on that category. So overall, the results of those 2 pilot studies demonstrated good structural validity, content and construct validity, and excellent test-retest reliability. And we wrote up that development of the CRIS in JARD, and that's the paper. So this was our pilot work, really, that allowed us to get the merit review funding to develop the CAT. So that's where we are. So this was funded by VA Health Services Research. So our fixed form measure took between 30 and 35 minutes to administer, which we felt was lengthy. We wanted to develop a computer adaptive test version that would be much briefer to administer, and then assess its psychometric properties, and then use the measure to compare and contrast community reintegration of 3 different groups of veterans. So this study had working veterans with no mental health problems, homeless veterans, and OIF veterans in it. We expected they would span a wide range of community reintegration. So we had 2 years of data collection, 2008 to 2010, and then for the new combat veterans, we had a 1-year cohort follow-up study where we re-administered the measure, and we also pulled medical record data so that we could look at predictive validity of the CRIS. So we looked at emergency room use and so on. Okay, so we also administered some concurrent measures, such as the SF-36, quality of life scales, a couple of measures from the chart. And as I mentioned, we extracted diagnostic and healthcare utilization data from the VA databases, and then linked them by Social Security number to our study data. So our full item set that we tested had over 300 items, and the questions were organized into 3 scales. This was our field sample. Actually, Group A, the 69 veterans with good community reintegration, they were the hardest to recruit because they generally had to be recruited from the community and not from within the VA. Although we tried very hard to get people who totally fit these categories, when we looked at the data later, there were 17 people who did not fit these categories. So we conducted exploratory factor analysis and confirmatory factor analysis on the item sets, and then refined the item sets and did rash models, looked at the fit of the item person map, and so on. So the resulting scales out of those 300 items were 77 items in the extent of participation scale, 144 in the perceived limitation scale, and 86 in the satisfaction scale. We did data simulations on these 517 subjects to see how many items would need to be administered to get precise scores, and we found that we could get good precision with 20 items on extent, 16 items on perceived, and 14 items on satisfaction scale. That we later did an administrative study, and we said that took on average 10 minutes to administer. This just shows you how we ordered the item hierarchies from difficulty level. Karen talked about how when you do an IRT model, you get the item difficulty level. And this shows the items at the top were the most challenging, the items at the bottom were the easiest to endorse. And here's a similar one for the satisfaction with participation scale. Unfortunately, it's so far away I can't actually read. I can't read those. I hope you can. Okay, so in summary, the CRIS-CAT is a population-specific measure that we developed for veterans. The scales had good construct, concurrent, and predictive validity. I did not present to you the ER data, but as I mentioned earlier, we found that CRIS scores at baseline could predict the odds of using emergency room, and we had 3 unidimensional scales. And there are 2 papers. The one on the left has been published. The one on the right is published ahead of print, so I didn't have a nice picture that report on the psychometric testing of the CRIS-CAT. So what does this all mean, and what does this mean for the development of other participation measures? Because as I mentioned to you, it's somewhat controversial in the field as to whether participation is a unidimensional construct or whether it's a multidimensional construct. But our data suggested that participation for veterans with the item content that we used was unidimensional, and that a psychometric approach to measurement was appropriate. So it also suggested that Annex 4 approach for differentiating between activities and participation was appropriate. This was very population specific, and I think further research would really need to be done to confirm whether this approach can be used with other populations. So one thing that can be done is that we could confirm the conceptualization of participation by reproducing this approach to look at other population-specific measures. We kept objective, subjective, and satisfaction dimensions separately in 3 separate scales. That's also something that could be looked at, whether they could be separated or blended. Although we developed this for veterans, I strongly believe that it actually is probably appropriate for people who've sustained traumatic injuries and been in other traumatic situations, and for people with psychiatric illness, because a lot of our sample had psychiatric illness. We have not yet validated this measure in those populations, but I'm very interested in doing so. So future research, we really need to do large cross-sectional studies to get normative values for the CRIS-CAT, and then longitudinal studies to look at the stability of the CRIS-CAT scales over time. And then what I'm really interested in is looking at the responsiveness of the measure to change after intervention that's designed to improve participation. That really is necessary for us to know, is this measure responsive, and to do some head-to-head comparison with other measures to see what measures respond to change and what interventions are effective at improving participation. Also, there's a great interest in looking at the factors that are related to participation, certainly personal factors in the environment, social support, these things that we know we strongly think are related, and other studies to understand how determinants of participation vary by age and sex and other factors. So I mentioned studies to look at the impact of environment and personal factors. So that's my email, and I'm very interested in your questions. So thank you.
Jacob Keene from Indiana University.
Thanks so much for your presentation. I wondered, you talked about the future work exploring the relationship between scales and looking at one score versus a profile where you had subdomain scores and maybe a total score. Have you done anything where you've even correlated the measures so you understand the relationship between total scores on any of the subscales yet?
Looking at the individual chapter level content and the relationship for each separate scale, is that your question?
I think so. I'm not sure. I think I understand what you mean by chapter level content, but I'm just thinking, if you have between a construct, so you have extent, you have perceived limitation, and you have satisfaction, what's the relationship between those things?
Right. That's a good question. Our work shows that the extent and the perceived limitations are fairly highly correlated. Satisfaction is less correlated. That's not always true for participation measures or measures that cover the area of participation, but I think it would probably need to be looked at in a population-specific way. But personally, I think that there might be very similar scores between extent and perceived. And one doesn't have to administer all three CRIS scales. What you can choose, there's the software that's developed, the CRIS-CAT software, which we've developed, is freeware. I'm happy to share it with anyone. But you get to choose in the beginning, do you want to administer all three, or just a single one, or two of the three, however.
Thank you. And one more question. You had a couple of initial pilot samples that you looked at the measure, and that isn't how I've typically read about how measure development proceeds, but I felt like it also gave you a window into the feel of the data as you're building this measure. Did you do that methodologically by design, or did that mirror the way that the funding unfolded for the project, or what drove that?
Well, I think both of those things. First, we wouldn't want to go forward with a large item set unless we had done some preliminary pilot testing and revision of the item set, because there's a lot of tweaking that needs to be done to really get the item set in each of the questions and make sure they're well understood and that they are being answered as we expect people to be answering them. So, but we also, the initial funding came through a TREP, that's a VA Health Services mechanism, and then we had some pilot money. So it came in several stages, but it also, I think, corresponded to probably good measure design, because I don't think it would make sense to move forward with the testing of a large item set and a large sample like that unless we had data to suggest that it was going to be robust and measure what we think it intended to measure.
Thank you.
Ken Ottenbacher.
Yes, thank you, Linda. That was a very nice presentation, very logical and systematic way in description of developing the instrument. I'd like to just follow up on a couple of your comments about the future research. So is there anything in the instrument that really would make it just unique to veterans and to service? It seems like it would be applicable, as you kind of alluded to in the ideas for future research, to a broader population, and you're interested in doing that. But I was just curious if you could talk a little bit, is there anything that would make it unique to service members? And if you do make it available to, or make it kind of market it to the larger population, are you thinking about changing the name of it?
Right. There are very few questions that actually use that are around veteran-specific questions. So I think there's a question about how often do you get together with friends who are veterans, and there's a question of how often do you get together with friends who are non-veterans. And the difficulty level of those was quite was quite surprising. It's much easier for veterans to get together with friends who are veterans than to get together with friends who are non-veterans. That's just how it worked out. But there are very few questions like that. And on the CAT, there could easily be, there are some screens set up so that people without children are not asked the questions pertinent to being a parent. People who are not working are not asked questions about that. So it could easily be modified so those very few questions that are veteran-specific, that use the word veterans, are not asked to people if they're not a veteran. But I think before you use a measure like that in a different population, we would need to establish the content validity. I had hoped to do that, but we haven't yet had a chance to do that work.
Well, that was kind of a follow-up. I was interested in when you did the CAT, if any of the items that were specifically or kind of unique to the veteran population, if they had showed up in the CAT as being really critical to the instrument itself, or
well, there is no item that's particularly critical on a CAT because you get a whole array of item difficulties. But I did notice that some of the questions for veterans about socializing were different, more difficult to socialize with people outside of the veteran experience. Those are the ones that I think of right now. There were not very many questions like that, but in our interviews with people, we knew that this was a phenomena that was true, is that people seek out others and they don't want to connect with friends from before who did not share the similar experience and may isolate themselves from people and so on. So there are very few items like that, but they could easily be filtered out.
Just one more follow-up, just because I'm not that familiar with the VA system. So I mean, you obviously spent a lot of time thinking about this and developing the ICF conceptualization for the instrument. How common is the ICF within the VA system and using that model? And if you adapt that, do other measurement instruments use the ICF model within the VA system?
No. And when we began this, it was in 2003 and 2004 that I began the proposals for this formative work. And the ICF, remember, was published in 2001 and is still really being accepted in this, particularly in this country. In other countries, I think it's much more widely accepted, but it isn't really being used. But as we could see with the CMS rules for functional limitation reporting, the ICF taxonomy is starting to get used and integrated. But I think there are very few measures that were developed with that taxonomy. Obviously, the PROMIS measures were not using that taxonomy. There are other constructs that we generally have been interested in measuring for health and rehab.
Thanks very much for your presentation. I work in a very different area. I study children with language disorders and the effects of language treatment, and yet the concept of reintegration, I think, could be very relevant to my area, especially if it's translated into such decisions as what's the full slate of factors we should consider when we're thinking of releasing a child from therapy, or when we're thinking of recommending that a child move from resource help to full-time in a classroom. I would imagine that there are things over and beyond an improvement in language skills that we should consider, such as improvement in self-confidence, the child's willingness to socially integrate with others, and so on. So I guess my question is, if someone were to are there any general tips that you might offer for people who might be considering developing or refining a measure of reintegration applied to an area such as the one I just described?
Right. I think the formative research is really crucial in figuring out who needs to be in the formative research to help you understand the challenges and to have a broad enough group of stakeholders to help get a very clear picture of what are the important aspects of integration for children that you'd want to measure. So I think that you really can't have good content validity without really good formative research to help inform you what should be in the measure, and then taking a look around what other measures exist, and then writing items that address that content area. But I got very familiar with the ICF taxonomy and its pros and cons, but there was a lot of international effort in terms of defining each one of those sub-chapters and what they mean. So there's a good starting point. I don't know, for children, I'm not sure if people feel that it is all encompassing. I don't work in the area of pediatrics, but there might be some thought that it might need to be expanded for children. Someone here might know more about that than I.
Travis Thritz from St. Louis University.
There is an ICF for children and youth that was published in 2007.
Thank you.
And it has a lot more developmental codes, like for language, it's a code called developing syntax, responding to voice, things that are not in the ICF. But could be of use to you, because the next step is they're going to combine the two, because it turns out that those ICF CY developmental steps are very important for both dementia and head trauma, because it could have an intermediary step that the current ones do not have. So the plan is they're going to be combined in a few years.
Very interesting. Thank you. I knew that there was some controversy in that area, because anything that it wasn't strictly coded in the taxonomy, there's an out that's called other, and you could put it under this other category. So there were some of the issues that we had that were just other, because there was no taxonomy and no real description of the kinds of functions that they were.
I'm wondering if there were some items that you worried about their validity, and I was thinking in particular, I was surprised to see in your ranking of item difficulty that thinking logically and critically kind of fell middle range, and I'm wondering, for the population, is that the kind of question that should be included in this? It raises issues of self-awareness, certainly, but also their their very subjective feelings, like, how do you enjoy something is different than, how logically and critically do you think now, or whatever the question was. And I don't know what the item was exactly, but I was surprised by its placement.
Right. Well, this is always a challenge with patient-reported outcomes, is that these are, even though I'm saying it's extended participation, we're having self-reported patient perspectives on how often they encounter a situation or how much limitation they have. I showed you the ordering of items, but with so many different chapters, where things fell out was sort of interesting. I mean, the easiest thing to endorse was personal cleanliness, and the hardest thing to endorse is recreation, participation in recreation and socializing. And then a lot of things were in the middle. But the thing to remember about a CAT or any measure like this is that the score is not based on one single item. When you only have single item measures, then you can have issues around reliability around them. But with multiple items, then you can narrow down the score so you can have more confidence that you're measuring this latent construct, which is participation. But it is. We did not do any concurrent validation of particular items against, say, like a neuropsych eval or something, to say what people endorse for how much limitation they have thinking clearly and logically, and how did that really correspond to real life objective function. But generally with physical function, which is what I know much more about, the correlation between self-reported physical function and performance-based physical function is moderate at best. People have their perceptions are not the same as an outside objective measurement. They're usually moderately correlated.
Just add that that's an interesting challenge in communication, because there has been some work to suggest that after someone goes through aphasia treatment, for example, both they and their spouse or loved one may have developed a greater awareness of their communication challenges. So in fact, it may look like there has been a decline in progress, but in fact, it's just that they're more aware of the problem. Did you have that as well? Concept?
We didn't look at that, but certainly this idea of response bias, because you've either changed somehow through treatment or your values have changed, and there's certainly an issue in all kinds of patient-reported outcomes. That's a whole nother area, very interesting.
Good. Carolyn Baylor from the University of Washington Department of Rehabilitation.
A response shift, I should call it. Response shift rather than response bias.
Thank you. I apologize if I missed this in your talk, but I was really interesting that you had a category of responses about how satisfied people were. And when Kathy and I and our team were working on our communicative participation items, we really wanted to ask people, how satisfied are you? And through our cognitive interviews with participants, our participants told us not to use that because it really didn't capture their experiences. They wanted a more negative wording about that reflected the problems they were having, not how satisfied they were. So we wanted to use satisfied but had to give it up. And I guess I was just curious if the satisfaction wording seemed to work well for you, if you got any kind of feedback about that.
Well, we did cognitively test all of our scales and the anchors and the words for each of the response categories for the scales. And we originally had been using the terrible delighted scale for satisfaction, and the veterans did not like the anchor words on that scale, which were terrible and delighted. They didn't think they would ever use the word delighted, and they didn't want to endorse a word, a response that was delighted. So we changed the response categories so they would be more acceptable. And a lot of the questions might have been, say for communication, we might have asked, how satisfied are you with your ability to make yourself clearly understood? We did not have any complaints about that, but again, when your measure is population specific and you're getting that kind of feedback from the people you're testing, it's worth taking a look at. We did not encounter that.